Okay, so just some introduction about Dr. Khoury today. He is a specialist orthopedic hip and knee surgeon with over 25 years of experience. He is also recognized as a revision expert and is able to assist with complex surgery. In terms of IME assessment, Dr. Khoury can assess all body parts except for some complex spine injuries for VWA matters. So over to you, Dr. Khoury.
Sophia, can we share the screen? Have I got this on sharing?
Sorry, can you try sharing again, please?
Yeah. Oh, here we go.
Does that work? Yeah.
Yeah. Is this good?
Yep. Yep, I can see it. Yep.
Yeah, great.
So can you make it full screen?
Yeah, I can. Awesome. Thank you. You happy?
Yep, that looks good.
Good. Thanks. Thanks for having me. Thanks, everybody. I always like to know kind of what my audience is because it's easier to talk to people and rather than just give a talk. But I've guessed, and probably correctly, that a lot of you are insurers, lawyers, and probably what you want to do is really think about what goes on in our brains and how we think about things. And my area really is complex joint replacement surgery, and I've been doing that for a very long time, and it's my training. And so today we're going to look at it from my perspective, your perspective, what happens, why patients get angry at us, and what we can do about that. Can I get rid of this sidebar here, Sophia? Can I? Yeah, I can do that. Thanks. So one of my mentors always said to me very early on, small surgery gives you small complications, and big surgery gives you very big complications at times. And, you know, sometimes with all the best of intentions, you can't fix that. You can't make that better. And of course, 25 years ago when I started, no more, 27 years ago when I started out as a surgeon, no one was suing anybody really, but seems to be that everybody's suing everybody these days for things that are in your control and things that aren't in your control. But everybody these days seems to think that everything's in your control as a doctor. And it's very interesting to note that the airline industry have adopted a system of incident response and incident investigation. And in the airline industry parlance, I'm the pilot. But these days, the pilot in medicine gets blamed for everything. But it's really most things are systems errors. And we've got to start learning to think like that. And we've got to start learning to think about what the problems are, what's beyond your control, what's good practice, what's bad practice, what complications are inevitable or couldn't be avoided, and who's responsible, because it's not always the surgeon, and it's not always the doctor. So when you go through, and these risks of surgery, I go through with these risks of surgery with all the patients, and we go through them in detail. And they're in no particular order, and they're in no particular order of importance either. But if you look down the list, you can see, and it's by no means exhaustive. Infection, dislocation, fracture, nerve complications and palsies, leg length discrepancy after hip replacement, stiffness, wear of the prosthesis, prosthetic breakage, complication, thromboembolic disease, blood clots. People can die. The death rate of even elective surgery in modern times is something like 1 in 1,000 still. It's not zero, and it will never be zero. No matter what you do, no matter how good we are, it will never be zero. So understand that. That's very important. Medical risks. When I was a resident at the Alfred Hospital in the early 90s. I was a very junior doctor running around looking after 30 to 40 patients on the orthopaedic ward, on the cardiothoracic wards, and people after surgery at that time, and I've seen the progression, used to be very sick, and a lot used to die. You know, the death rate was very high, and the death rate was high due to cardiac issues, delirium tremens, DTs, a whole bunch of issues, and it's a, you know, it's a credit to medicine that we got people through all of that. And in modern times, you know, most people are free of complications and usually get through their surgery, but they're living a lot longer, and probably the risks are higher, but we're sort of better at coping with that. So the public have sort of got used to the fact that we can manage most things. So when stuff happens, you know, people don't really think that that inherently surgery isn't safe. So we talk about medical risks. We talk about revision risk, and we talk about, and I always talk about the risk of my colleagues, because my colleagues pose a risk. Infection. Well, infection's big. It's one of the big hitters on the joint replacement registry nationally in Australia. It occurs less than 1%. We quote about 0.5% of deep infection after joint prosthetic replacement, but in reality, it's probably a little bit more common. It's a leading cause of revision. It can reduce your life expectancy. There have been numerous papers written about this. We can do 1 or 2 stage revisions to cure an infection, or so-called cure, in inverted commas. And 1 and 2 stage revisions have a 90 and 80% chance of curing, or the other way around anyway, infection. Sometimes patients can't be cured and have to have lifelong suppression on antibiotics, and that has its own morbidity. Sometimes we can wash a joint out without revising it, but again, that has its own morbidity and recurrence rate. And always remember, I always talk to my patients and say, orthopedics is a team sport. Surgery is a team sport. It's not about just me delivering an end product. It's about them doing what they're meant to do and not breaking our pact, because a lot of problems occur from patients being unclean, unkempt, undernourished, don't look after themselves, have falls post-surgery, but of course we get blamed. This is one of mine, and this is one where I've taken the joint out and put a cement spacer in and then replaced the joint. And we've cured this infection. This is one of the ones I have cured, which is good. Most of this is my stuff that you're going to see, except for the stuff that I tell you is not. This is one where I removed the femur and put a prosthesis in that replaced most of the end of the femur. So infection risk, really, because it's a big one and sometimes leads to suing, is multifactorial. And again, this is a list that is not exhaustive, but it gives you the main risk factors. Patients who are diabetics, they smoke, they're immunocompromised, they take drugs, biologic drugs for rheumatoid arthritis, obesity, repeat surgery, revision surgery, prior infection, poor nutrition, are all risk factors for infection. What can we do? Well, it's really hard. Control the diabetes. I always send patients to a physician to try and do that. Weight loss, very difficult to ask your patients to lose weight. Stop their immune suppressive drugs, make sure their medical conditions are under control, make sure they're not malnourished. Stop them smoking, for sure. Make sure your operating environment's good, give them antibiotics. Technical issues in the operating suite, controlling traffic, controlling personnel, movement, air conditioning. Don't mess around. Make sure your surgery doesn't take longer than it's meant to take. Transfusions are related to increased risk of infection. And I like to get patients out of hospital early because that reduces their risks. Hip dislocation. That's one of the one of the reasons that people might sue you. I always say it's less than 1%. It may be related to how you approach the hip. It's related to patient factors, whether they're compliant with their rehabilitation. There are surgeon factors. Obviously, I need to do the operation properly and place the prosthesis properly. Prosthetic factors. In the old days, prostheses weren't really designed well. Now they're designed better and they dislocate less. And there are numerous design factors that allow us to give a better operation and a more stable prosthesis. Again, it's one of the leading causes of vision. It's largely preventable, but there are a lot of patient confounders. This is one I prepared earlier. This is one that a local patient who was seen in Sydney and fractured her hip. So she had a hip replacement because she was only 50. And that's what you would do. It's good treatment. But unfortunately, she dislocated 11 or 12 times. And as you can see here, the socket's a little bit vertical. Okay, so it's been malpositioned. So they revised the socket and put it in vertically again, which is, kind of a bit crazy. But anyway, there you go. So she came to me, and I spent ages with this woman talking to her about all the potential outcomes, because she basically by that stage had more than a dozen dislocations, two failed surgery attempts, and here I was at the receiving end of it all. And so we talked her off a ledge, and I started again. I took the whole hip out and cement. You can see here my osteotomy to remove all the cement. So I opened the femur like a book, put the prosthesis in, cemented it again, and I put a new cup in a better position, and she hasn't dislocated since. So that's good. Another problem is fracture, the hip replacement or knee replacement. And it's usually due to patient falls. Sometimes certain prosthetic types are prone to fracture. Sometimes doctors do it. Dr. is a leading cause of fracture, and sometimes it's related to approach. Anterior approaches at the moment cause more fractures than normal. And sometimes we either fix or we revise. This is one I've seen, an exploded femur from a fracture, and we fix that. Again, these are fractures of knee replacements, and you can see the knee replacement here, and you can see the fracture down here. And with knee replacements, we don't really revise them, we fix them. And this one was fixed. And again, another fracture with fixation below a hip replacement. Nerve palsy. This is the one that gets us into trouble too. Usually occurs in two common circumstances: over-lengthening a leg in total hip replacement, and also correction of significant deformity in knee replacement. It also happens in hip replacement with prior pelvic trauma, more common in revision surgery in knees and hips. We talk about valgus knees. That's the common deformity where it's a knock knee deformity and we have to correct them to straight position. Prior nerve injury can be a predisposing factor, and sometimes poor nursing on the wards can lead to nerve palsy. Sometimes when patients lie on their nerve, some nerves are superficial, like the perineal nerve or the radial nerve, and they're poorly nursed. You can see a foot drop and you think it's part of your surgery. The middle one is the valgus deformity, the knock knee deformity. So you can imagine if you straighten that to straight, sometimes it can put pressure on the nerve, and the nerve runs from the sciatic nerve down the thigh and around the outside of the leg and supplies the muscles and sensation in the leg and the foot. So it's not a direct injury per se. Let's go back. Back. Yeah. So it's not a direct injury per se, And a lot of people, you would think that the surgeon has caused the injury. Well, indirectly, probably yes. But this is part of the consent preoperatively, is when I see patients that are risky and may suffer a nerve palsy, I let them know that that might be a possibility. And it's not me cutting the nerve or putting direct pressure on the nerve. It's the fact that the nature of the surgery to correct deformities or increase leg length can cause a problem. This is one I prepared earlier. This is a young lad from Nigeria who suffered congenital dislocation of his hip, and he was 5 centimeters or 6 centimeters short, and presented with pain, couldn't walk, play soccer, and generally was disabled for a 19-year-old. So we replaced his hip and brought his hip right back down to where it ought to be. And I took about a 1-inch segment out of his femur to shorten his femur so I can get his hip reduced. If I hadn't done that, I wouldn't have been able to reduce his hip. But in doing so, we risked giving him a palsy, less so by shortening his femur. But I spoke to him about that preoperatively. We've still left him about 2 centimeters short, but he tolerates that. If we lengthened him any more, we surely would have probably given him a nerve palsy. But he's very happy, running around and pain-free. Leg length discrepancies tolerated. It is common and is tolerated mostly because we lengthen people's legs by less than 5 millimeters. I always consent people because of that, and I always tell them that there are all sorts of issues that can lead to a leg length discrepancy, and most of it is unavoidable. There are prosthetic issues, there are soft tissue issues, there are ligament issues. Sometimes we lengthen on purpose. But this is very common in lawsuits, and some patients are very unforgiving. To be honest, you should be happy that you have a hip replacement that gives you a pain-free function. But significant leg length discrepancies, sometimes occur, and they're probably not the best. We talk about wear and loosening. That's also a common cause of revision. We have better materials these days than 20 years ago. We have better surgery. It's much less of a problem than it used to be. So wear. This is a patient of mine who had an old Charnley hip replacement done 40 years ago. I'd revised their socket about 20 years ago, and even that's going south now. But you can see that there's erosion of the femur. There's wear of the plastic because the head's sitting eccentrically in the socket. The socket has been malaligned from where I put it 20 years ago. So she came to me and we revised this, and she's really happy. I saw her down the street the other day and she was thrilled, gave me a hug, which was nice. You don't get that much. Other things like this 30-year-old prosthesis where the cup suddenly flips and you've got a pelvic dissociation. I'd revised his cup earlier to that. He'd done the same thing on that side, and I'd revised his cup. This is another complication. I don't know if you can really see it, but I'd done this knee replacement about 2 years ago, and the patient came to me with pain and like a loose body in his knee, but the plastic behind the kneecap dislodged, and you can see it just there. And that was after a fall, very traumatic fall. This patient's like 150 kilos. So venous thromboembolism, death, and overall revision risk. Well, when you look at the joint registry, and this is old data, but the cumulative percent revision of primary total knee replacement is about 6% over 12 years. For hip replacement, it's roughly the same, 6 to 8%. So all of us, so hip replacement's very safe these days. So all of us can actually say to our patients, look them in the eye and say, we're going to do your hip replacement. It's going to be good. The likelihood is that it's going to last more than 20 years. And that's true. Most patients are forgiving of complications. We spend a lot of time talking about complications. Luckily, they don't happen often. One of your biggest risks is your colleagues who think that they can do better than you, but don't actually do better than you. And I do a few, med-neg reports where it's very interesting, where I see what my colleagues are thinking, and often it's interesting to see what they're thinking because medical negligence is a very interesting area. A lot of it isn't negligence, and a lot of it's just finger pointing and people thinking that they're better than you, and maybe they are, maybe they're not. I don't know. But you can't just assume that you would be the one that, because you do things differently, would never have that complication. And the other thing is that we should be very careful as practitioners in the way we report the scientific literature, because I see a lot of scientific literature misreported, a lot of level 4 evidence tendered in court as fact and not just supposition. And it creates problems because, from my perspective, if you're not providing good evidence, factual evidence, and good evidence-based literature, then you're doing the plaintiff a disservice and you're doing the defendant a disservice one way or another. And so our colleagues are our own worst enemies. We're all our own worst enemies because we think we're better than we are. We're pretty good, but we're not brilliant, and most of us are hard workers, do good stuff, and it works out pretty well most of the time. So my message is keep thinking about all of these things because they come up often, and you have to go in depth for all the reasons why these things occur. It's not just because the pilot has pointed the nose to the ground most of the time. And so thanks. Over to you if you want to ask some questions.
Hi, everyone. If you have any questions, you can just unmute yourself, or you can pop in the chat box. So we'll probably wait here for around a minute or so. Okay, it seems like we don't have any questions from the attendees. But if you guys, I will publish this on our YouTube. So if you have any questions, then you could always send us an email and then we'll pass it on to Dr. Khoury.
There's one on the chat.
Oh, okay, yeah.
What is a suitable age for knee replacement? That's a good question. The orthopedic literature tells us that patients over 55, under 55, males, heavier people tend to do less well. So statistically speaking, if you want to do a knee replacement on somebody, you probably would be better served waiting till they're 55 or more. Unless, of course, they're severely disabled with severe disease and can't walk, well, then you have to do something. But ideally, statistically, the better patients are over 55 or 60.
Yep, thank you, Dr. Khoury. Does anyone else have any questions? Yep, another one just came through in the chat box.
Okay.
So when both knees, hips warrant treatment, is there best practice for bilateral or one-by-one procedure?
Yeah, that's another good question. Bilateral procedures can be indicated if you are under a certain age, probably young, healthy, American Society of Anesthetics, ASA class 1 or 2, very little disease or systemic disease. Elderly patients probably would do better with, staged knee replacements. However, a lot of people would probably debate me on that because, if you stage them, then you introduce new risks of, having surgery 6 to 8 weeks apart, the inherent risks of, further surgery, further anaesthetic, increased risks of blood clots, death, or if they've got pre-existing cardiac disease, it can re-aggravate that. There is no right answer, but some patients can't tolerate, lengthy surgery or a 3-hour anaesthetic, and so you have to stage them. Usually what I do is talk to my anaesthetists, talk to my physicians, and if you do bilaterals, I would have them in a facility with an ICU or a HDU so they can be managed appropriately.
Yep. So another question came up. Had client who sustained hip injury after knee surgery. Is that possible?
Yeah. Hip injury after knee surgery could have. It depends on the circumstances. Or did the hip injury precede the knee surgery? And was the knee pain referred hip pain? Who knows? That's a good question. Don't know. Anything's possible. And then the other one is, what do you consider reasonably necessary treatment in delaying an inevitable TKR in an elderly patient? Okay. Well, it depends because some patients present as no-brainers. They've got such severe disease that PRP or Synvisc or anything isn't going to help them. But if you have a patient that's in their 50s, early 50s, late 40s, significant disease, or not significant disease, not enough to warrant a knee replacement, sometimes you can use PRP, Synvisc, weight loss, physiotherapy, GLAD programs. All of those sorts of things are very helpful. And that's what I do when I see patients that are not particularly, one way or another. You can do all of these things. Mind you, Synvisc and PRP aren't necessarily what they're cracked up to be, and there's not a lot of evidence to suggest that they work better than nothing.
Yeah, thank you so much, Dr. Khoury. Does anyone else have any questions? You can just unmute yourself as well.
Yeah, I've got one actually. Hi, Doctor. Apologies if you answered this one already. I have a few people who have a work injury or a CTP injury, and their knee, for example, is really dysfunctional. They got a lot of pain, and there's a lot of things they can't do. For example, their kids, like run around with their kids or something.
Sorry, I can't hear some of that.
Oh, sorry. Is that any better?
Yeah, that's better.
I've had a few people who have a workplace injury or a CTP injury, and they have quite poor function in their knee and quite a lot of pain that prevents them from doing things like playing with their kids. And they're often in their like 40s or 50s, and surgeons say, oh, you'll need a knee replacement, but we won't do it now. We'll do it in, when you're 60 or 70. And the patient thinks, well, why wait until I'm 60 or 70? Because when I need my knee to work is now. I was just wondering what your take on that is. Because they say, well, I don't need one. I don't need a knee replacement. I don't care if I can't walk when I'm 67.
Well, I've certainly done knee replacements in patients who are 35, 40, 45, but they're rare, really rare. And there are significant circumstances that lead you down that path. So, but in run-of-the-mill cases, you know, most people can be managed with a bit of psychological help, physical therapy, a bit of joy in their lives, weight loss. A lot of people focus on their problems, which aren't necessarily severe, and we see that a lot. And I see that a lot, and it's very difficult for me to talk about because people don't see it. They're you know, a lot of them are depressed, hate their lives, hate their jobs, and I don't like saying this, but it's true, and you can see it on their faces. And so when you say to people, you know, yes, you've got a problem, but that problem can be mitigated by other things, all the things we've said, you know, thin visc, PRP, weight loss, exercise, specific forms of exercise, GLAD programs. They don't understand. And the other thing is, you know, we all carry something, you know, like it may not be a knee injury, it could be something, but you need a certain amount of joy in your life to be able to get through and be happy. And it seems to me that some people are missing that, you know? And I don't know how you communicate that, and especially in the work cover arena. People get consumed by their problems, and we all do, and we're all prone to that. And so, you know, no one in the room, you know, is immune. But these things can be made so much better in a way, but I don't know how to do that and communicate to my patients all of these sorts of things, because it's very important. But there are a lot of things that go into this, you know, and you know, when you think about 1/3 of the population are depressed, you know, the psychiatrists will tell you that. So if they're all, you know, if all these people are depressed, how many of your patients walking through your rooms are depressed? Yeah, and treating that, you know, with drugs is one thing, but how about a bit of joy in your life? You know, where do you get that? You know, how do you do that, and how do you take your mind off what's going on around you? Because that could be a lot better if your brain was a lot better. You know.
Definitely. Thanks.
That's all right.
Thank you, Helen. Thank you, Dr. Khoury. So does anyone else have any other questions? I think we could wrap it up here. But thank you so much, Dr. Khoury, for a very informative session, and a very interactive Q&A session as well. And thank you everyone for joining. So this will be published on our YouTube channel, and we will send through the slides to the attendees who signed up for this seminar. Yeah, Dr. Khoury, do you have anything to add, or?
No, I think that's all good. Unless anyone else has any more questions, I'd be happy to answer them, but that's great.
Yep, everyone's sending their thank yous in the chat box.
Thanks very much. That's excellent. Thank you.
Okay, all good. Thank you, everyone. And we hope to see you again in future sessions. Thank you, Dr. Khoury.
Thank you. Thanks, guys. Bye-bye.
Bye.